I guess what I can speak about, though, in relation, or I guess in relation to the question, is more so a lived experience perspective in terms of that there is also quite a lot of inequity, or I guess a pervading belief out there that children and youth are the same kind of age group, I suppose, and that they need the same things, they have the same needs, the same wants, and that interventions directed at them should be the same, therefore. Naturally, that's not correct, but this is something I very much experienced myself when I voluntarily went to a psychiatric hospital, and I wasn't put in the same, I guess, unit, you would call it, as people of my age. I was 19 at the time. It wasn't people maybe, let's say 17 to 18 to maybe 21. It wasn't people of that age. It was people that were 40 to 50 plus and had, in their words, been there for a very, very long time. So maybe 3 to 4 years. Naturally, that was very shocking to me. And that is, I guess, just one experience among so many other young people that so many other young people have told me about, that there is still a lot of inequity to tackle. Thankfully, it is now receiving a lot of attention in the field of transitional psychology and transitional psychiatry, which are looking at those exact age ranges of youth. So we're thinking let's say, people define it quite differently depending on the study and all of that. But let's say the ages of 18 to 25, it's receiving a lot more attention now. So I have some hope, but it is an issue that is not to be understated. But I think I guess, harkening back to my own experience as a peer supporter, I would like to focus on one particular solution that I'm very passionate about, which is very much one concern with rethinking how we can deliver care, so that it really involves moving away from the centralized hospital-based models, of course where appropriate, that have dominated the mental health care system of many countries for a long time, and moving more so towards community-based and person-centered services that are also integrated into primary health care. Now, of course, that is a lot easier said than done. There are many great examples, like integrated use services. For example, in Canada is one example where they did, in fact, integrate it into primary healthcare. We see Australia as well with Headspace, where they also share the same building as primary healthcare clinicians. But regardless, it is a lot easier said than done. And I guess what I'd like to say to that is that we don't have to start there. We don't have to immediately start at integrating, at immediately both developing community-based mental health care initiatives and then immediately integrating them into primary health care. It's a very long process, and it doesn't mean we can't act already. We can already kind of take the burden off of the mental health care system with, at least in my view, a greater investment into community-based care, with, of course, the long-term goal of also integrating these into primary health care later. And this is something that I imagine a lot of perhaps countries with smaller or relatively smaller budgets allocated for mental health might find very interesting, like an interesting way of testing the waters. Because there's quite a lot of, I guess, community mental health care services out there that maybe aren't immediately or are still working on integrating themselves into primary health care, but still add a lot of benefits. So I would name one example being At Ease, which is a Dutch community mental health care service where they essentially offer walk-in services, walk-in centers, where young people can walk in and they can receive psychological support. And these peer support workers are also then supervised by clinicians, and there is a very strict protocol when it comes to things like crisis situations and how to handle them and how to refer them. And so even though organizations like At Ease are still very much working very hard on integrating into primary health care, it still is very much effective. So we don't have to, see this very big daunting goal in front of us and think, oh my God, how are we going to start this, or where can we start? It requires so much investment. We can start with the pre-existing methodologies that are out there. We can start with the pre-existing interventions that are out there and move towards integration as a long-term goal. I guess this session for me has almost been like seeing my own advocacy journey kind of in front of my eyes, in the sense that we started with a very dire picture of mental health, the fragmentation of mental health financing, like putting the fact that, there's an ever-increasing, mental health is only getting worse, and then on the other side, we have mental health financing not really keeping up with that. So we really started with a very dire picture, and that's kind of what I experienced as well, starting out as a mental health advocate. But then we moved on towards a picture of hope. We saw the power of training youth to help other youth. We saw the power of lived experience, engaging them, the power of engaging the community, the power of anti-stigma work. We saw so many and heard about so many very interesting and very powerful interventions and examples of ways we can help people with mental health issues. And so I guess, just as much as we started on a very dire note, we end on a note of hope.